So I am Emily Benson from the Ventura County Medical Center, and I'll be presenting on pain management in acute musculoskeletal injury. Hang on one second, I'm having some. Okay, there we go. Okay, there we go. Okay, so I'm presenting on pain management in orthopedic trauma patients, and specifically I'll be discussing this article and the recommendations put forth by this group. This is the clinical practice guidelines for pain management in acute musculoskeletal injury written by the OTA Pain Task Force, and this was published in the Journal of Orthopedic Trauma in May of 2019. This article was written in response to the opioid epidemic with which we're all very familiar. This epidemic has developed over roughly the past 15 to 20 years, and during that period, fatal drug overdoses tripled and almost 500,000 people have died. And to give that some perspective, a little over 2,000 deaths have occurred in the US so far from the coronavirus. Orthopedists supply approximately 7.7 of all narcotic prescriptions, though we make up only 2.5 of the nation's physicians. And studies show that if patients remain on narcotics after 3 months, there's about a 50% chance that they'll remain hooked for 5 years or longer. This paper set out to provide a guideline that we all can use to standardize the treatment of pain related to fractures. They note that much of the current pain guidelines have been based on treatment of chronic conditions, and these aren't always applicable to an orthopedic trauma patient. The task force consisted of 15 members who are all either orthotrauma or pain management experts. They did an extensive literature review, then created their recommendations. This is a comprehensive review which touched on basically every element related to acute pain management. And we'll go over all of these categories further now in sequence. In terms of cognitive strategies, the authors made 3 strong recommendations here. The first is to discuss pain and the expectations with your patients ahead of time. This is a strong recommendation, though based only on moderate quality evidence. Also, connect your at-risk patients, whether it's those with addiction issues, poor coping mechanisms, high anxiety, post-traumatic stress disorders, to psychosocial interventions and resources. Also recommend to your patients anxiety-reducing strategies, such as I tell my patients not to expect to get a lot of sleep the first couple of nights after surgery and instead line up a bunch of movies to watch. The article lists aromatherapy, music therapy, and cognitive behavior therapy as some other possibilities. In terms of physical modalities, the panel recommends TENS, or transcutaneous electrical stimulation, though they don't recommend a particular type of device or protocol. There are not a lot of standardized clinical trials on TENS, but it seems that pain control is related to the current amplitude. It needs to be significant enough, but not enough to cause pain, and they call that the maximal tolerable level. They also note that a less common setting called interferential current is showing some more promise. However, they admit that more research in this field needs to be done. Cryotherapy is recommended, but they recommend it rather half-heartedly, and they report no difference between types of delivery devices. The literature is definitely mixed on this. The area of opioid safety and effectiveness actually has the highest quality evidence. We've found that people on higher doses and longer durations are more likely to become addicted lifelong users. Same is true for long-acting drugs over their short-acting cousins, even though this was popular only a few years ago. Combining benzos with opiates leads to a 3.9 times higher risk of respiratory depression. And similarly, providing ranges on your prescriptions may also lead to adverse events. So try not to do that. Multi-modal analgesia is recommended, and this includes both opioid and non-opioid medications such as NSAIDs, steroids, gabapentin, and also certain types of injections. There's just not enough evidence to support one type of strategy over the other. Opioid tolerant patients particularly benefit from these strategies, and when treating these patients, it's important to have only one prescriber of narcotic prescriptions. And I usually ask my patients pre-op to touch base with their pain management specialists and let them know that they'll be having surgery and they'll need a post-op pain prescription. I also let them know that despite what we give them, we'll have a difficult time controlling their pain post-op. They also provide some more detailed advice on dealing with methadone patients and those on illicit drugs. Historically, NSAIDs have gotten a bad rap due to animal models and small, underpowered clinical studies, but after a thorough review of the literature and weighing the great pain control benefit that these provide, the panel strongly recommends their use. They note that there are similar studies that show that opiates may also inhibit bone healing, so you can't really use the argument for opiates in lieu of NSAIDs. There's some suggestion that bone inhibition is dose and duration dependent, and for this reason, I don't typically recommend chronic long-term use of NSAIDs, but I do liberally use them in the short term. In terms of regional blocks, regional nerve blocks such as fascioiliacus or femoral nerve blocks have been shown to be of benefit in hip fracture patients. And Dr. Lynn alluded to that in her talk. These are sometimes performed preoperatively in the emergency room, and they've been shown to decrease narcotic usage and delirium, but they do require a systemic approach which can be challenging to implement by an orthopedic surgeon. Similarly, blocks have been shown to have benefit as part of a multimodal strategy. Continuous catheters work better than single shot blocks with less rebound pain, but this is a conditional recommendation with only moderate quality evidence. In terms of assessing for pain and sedation, this is an area in which the authors felt strongly, but there isn't specific literature to support this. It's somewhat common sense to think that standardized assessing for pain and sedation probably will decrease the amount of narcotics distributed. And in the case of naloxone, this could prevent a catastrophic overdose. In terms of systemic strategies, they recommend that all providers register to gain access to your state's PDMP program. These programs are somewhat controversial. They definitely have their pluses and minuses. Their usefulness also varies from state to state, but there's some literature to support the idea that these decrease redundant prescriptions and therefore decrease the number of narcotic pills out in the community. Education is always a good idea, and studies have shown that prescribers who are educated about pain control tend to write for fewer tablets and fewer refills. They discuss a number of different educational tools, from physician one-on-one champions to CME talks. The EMR can be a good way to educate folks by automatically making prescribing recommendations through the use of power plans and alerts, and you're probably already familiar with the pros and cons of those. In my department, we found that it's been helpful to have a conversation about our prescribing habits, and our attempt to standardize our prescribing for various conditions has resulted in both a benefit to our patients and to us. So I'll leave you with the tables that this article has provided for a taper of multimodal pain control. This first one is for minor injuries such as simple joint fractures. It involves the use of narcotics for up to 3 weeks. The subsequent table is for major injuries such as long bone fractures, which involves the use of narcotics for up to 1 month. My group has done a fair amount of research on short-term use of narcotics, and as a result of this personal research, I find their narcotic recommendations to be somewhat excessive. You can review these yourselves and make your own determinations about this. But the research that we've done reveals that a majority of patients are able to taper off of their narcotics by 2 weeks post-op, regardless of the severity of their injury. The authors of this paper do note that there's no direct correlation between pain intensity and severity of injury, but it's more closely linked to psychosocial factors. They use some foreign countries as examples who use no narcotics at all following major surgeries. I found that clear pre-op discussions about expectations can go a long way. And when you tell your patients that you'll expect they'll be able to taper off of their narcotics by 2 weeks post-op, I found that they're generally able to do so. So to summarize, we all have our own ideas about the proper balance between patient safety and comfort. These authors put a heck of a lot of time and work into this paper, and I'm grateful for their effort to do so. I found it to be a very valuable, user-friendly summary of pain issues. Though I disagree about their narcotic durations, I agreed with just about everything else in here, and I hope you found this summary helpful as well.
Thank you, Emily. So that was an excellent review of that paper. But I'm interested in your approach. So I think, I agree with you that it's nice to have the people off in 2 weeks. So how do you accomplish that? A lot of the trauma patients, you don't get to have that preoperative discussion. So you've operated them on the hospital. How do you then? Do you do anything special to wean them off over the next 2 weeks?
Yeah, so I think it's more difficult when there are more patients or more doctors prescribing pain medications for the patients. So if the patient is on the general trauma service, it's very difficult for us to completely control what the patients are getting. Also, because that service is kind of on the front line, I tend to give them quite a bit of leeway in how they want to handle the pain control while the patient is in the hospital. But I do, unless my patients are intubated and unable to have a conversation about it, I do, even for my inpatients, give them my expectations that even though they may have multiple injuries, that the pain medication really is only helpful for the first few days after surgery, and they're likely to build up a tolerance to it pretty rapidly. I also have this whole spiel that I give them about how, our body has a natural way of dealing with pain. But if you continue to give your body narcotics for over 2 weeks, it's really challenging for your body's normal way of dealing with pain to kick in at that point.
Do you give them any kind of prescribed program for coming off? So I've found, in the patients that I have, similar sort of patients that I want them to come off in 2 weeks, they had their thing. I found, unfortunately, when the patients leave the hospital and they get their script for, 5 or 10 of oxycodone every 4 hours, they are following the prescription's guidelines and they have pain, so they're taking it every 4 hours. So I generally write them a specific plan for how to wean off over 2 weeks and give a similar spiel that their body will take over managing the pain. Do you do anything like that?
Yeah, I don't typically give them the taper that I want them to do in that 2-week period after they leave the hospital. I just give them kind of a general guideline, and I say, even though the bottle is going to say you can take this every 4 hours, I highly recommend that you take the bare minimum that you need to get by.
Good, thank you.